invitat pentru această prezentare pe doamna profesor Mona Amin de la Universitatea din Cairo. The next presentation is drug-induced liver injury and overview. And for this topic, I invited Professor Mona Amin, one of my best friends from University of Cairo. Mona, please, you can present your topic.
Is it clear on your screen?
It's, yes, okay.
Okay, thank you very much, my dear Professor Carmen, for the kind invitation to participate in your wonderful meeting and to meet my friends again from Mayo Clinic. My topic today is drug-induced liver injury and overview. First, this is my disclosure. Actually, drugs are one of the many assaults that affect the liver. And the incidence of drug-induced liver injury in the population is not well known. Drug-induced liver injury actually account for 10% of all cases of acute hepatitis. And it is a common reason for failure of pharmaceutical during drug development and is the most frequently cited reason for withdrawal of approved medication from the market. It is the most common cause of acute liver cell failure in the United States. The wide range of presentation and the culprit agent and the lack of objective diagnostic tests makes its diagnosis and management particularly difficult. The types of drug-induced liver injury, it is either acute or chronic. And the acute, it is of two types. One of them is that tended to affect all individuals to varying degree, that is predictable, and it is typically dose-dependent. This is the intrinsic drug-induced liver injury, and the prototype of this one is the paracetamol overdose. And the other one, which tend to affect only rare susceptible individuals, less dose-dependent, and more varied in latency, presentation, and course. And it may be immunoallergic like phenytoin or metabolic idiosyncratic like INH. While chronic drug-induced liver injury, failure of return of the liver enzymes or bilirubin to the pre-daily baseline, or the presence of signs and symptoms of ongoing liver disease such as encephalopathy and ascites 6 months after the onset, this is considered chronic drug-induced liver injury. These are some examples of the drug associated with both types of drug-induced liver injury. The prototype of the intrinsic is the acetaminophen. Many of the antimicrobial, anti-epileptics, and the very long list of drugs that cause idiosyncratic type of drug-induced liver injury. As we see here from the population based in Spain, for example, the anti-infective medications is number one. Come next is the nervous system anti-epileptic drugs. While in the USA and Iceland, anti-infective again is the first drug causing drug-induced liver injury. Then comes the dietary, the herbal and dietary supplement as a cause of drug-induced liver injury. While in the Latin American, the non-steroidal anti-inflammatory is in the top list. Coming next is the anti-infective and anti-androgenic drugs. What is the pathogenesis? The drug needs to have a lipophilicity, a dose that generates a reactive metabolites acting to combine important proteins and deplete the glutathione, causing stress kinase activation, mitochondrial stress, release of reactive oxygen species, endoplasmic reticulum stress. All this, if it is lethal necrosis of the tissue, this is the intrinsic drug-induced liver injury. When it is sublethal, an adaptive response with mild elevation and non-symptomatic syndrome of adaptive response, or in a genetically susceptible individual with co-stimulation of both the innate and the immune response, symptomatic idiosyncratic drug-induced liver injury will occur. And actually, there is an interplay between a possible host factor, for example, genetic variance, age, nutrition, alcohol, smoking, microbiota, medications, disease comorbidity, etc., and the lipophilicity of the drug and the drug dose. A minimum dose for the idiosyncratic drug reaction needs a 50 to 100 milligram. This both together leads to a host response to injury of inflammation, tissue injury, repair, contributing to the clinical manifestation and outcome. And actually, the response of the liver is a multitude. It may be hepatocellular, cholestatic, mixed, regeneration, and also can mimic any of the known liver disease. The clinical presentation of drug-induced liver injury varies widely from asymptomatic rise in the liver enzymes to an acute liver cell failure. Non-specific symptoms such as anorexia, nausea, vomiting, upper quadrant pain, skin rash, dark urine, pale stool, or itching, and a patient with severe or chronic DILI might suffer decompensation with jaundice, ascites, or encephalopathy. Diagnosis of drug-induced liver injury, there is no specific or diagnostic clinical presentation, laboratory test, or histologic pattern to aid in the diagnosis of drug-induced liver injury. It needs a high index of suspicion, and it is the diagnosis of exclusion. The first step to diagnose drug-induced liver injury is to take detailed history regarding the onset of symptom, the time latency from drug intake and the appearance of symptoms, drug dose, the route of administration, duration, previous administration, and any concomitant liver disease. And also you have to ask about the use of herbal products, dietary supplement, over-the-counter medications, and alcohol. History taking is greatly enhanced by the knowledge of the most common and the most rarely implicated DILI agents. The second step is to know the pattern of liver injuries, that is to calculate the R value, the elevation of the ALT above the upper limit of normal, above the elevation of the alkaline phosphatase above the upper limit of normal. If this value is more than 5, this is a hepatocellular pattern of injury, and the first line of test to be performed in this case to exclude other viral causes, acute viral hepatitis, autoimmune hepatitis, and do an abdominal ultrasound. And if these are negative, the second line test is on a case-by-case basis. For example, if a patient is younger than 40, you have to exclude acute Wilson by cerebroblasmin test, but keep in mind cerebroblasmin is an acute phase reaction, and if it is normal or low normal, you have to screen for 24-hour urinary copper excretion. You have to exclude the less common viral etiology as hepatitis CMV, herpes simplex, and Epstein-Barr virus. And the area of biopsy we will discuss later. And if the R ratio is less than 2, that is the more rise in the alkaline phosphatase, so the first investigation will be imaging, and the first imaging modality will be abdominal ultrasound to exclude extrahepatic obstruction, and the second will be on case-by-case basis, either MRCP or MRCP, and serology for primary biliary cirrhosis. If it is between 2 and 5, we will investigate as hepatocellular in addition to abdominal ultrasound to exclude an extrahepatic cause of obstruction. This is the second step. The third step is causality assessment. There are many scales to assess causality assessment. The most widely used one is the ROCAM score, which uses 8 items: the time of onset of elevation of liver enzymes after the start of the drug, more than 50% decrease in the liver elevation after the stopping the drug, negative hepatitis screen and ultrasound, hepatotoxicity is in the label of the drug, no concomitant medications, positive re-challenge, and the 2 risk factors, alcohol or pregnancy, and the age above 55. And the score more than 8 is highly probable that the drug is causing the manifestations on the patient. The causality, the re-challenge is one of the causality assessment, but deliberate re-challenge with the causative drug in clinical practice is not advocated unless the clinical scenario demands such an exposure, as it can cause more severe hepatotoxicity, while controlled rechallenge after an episode of liver injury is, however, considered justified in relation to oncology and anti-tuberculous therapy, as they generally don't result in severe recurrence of hepatotoxicity. The fourth step is to expose the drug on the liver tox, which is a free and helpful online drug-induced liver injury resource consisting of detailed information on more than 1,200 agents, and it is updated periodically. The fifth step is when to consider liver biopsy. Liver biopsy is strongly recommended if autoimmune hepatitis remains a competing etiology and if immunosuppressive therapy is needed. Also, if there is unrelenting rise in the liver biochemistry or signs of worsening of liver function despite stopping the suspected offending agent. And in case of drug-induced liver injury where continued use or re-exposure of the implicated agent is expected. Also, it is indicated if the peak ALT level not decreased more than 50% within 2 months after the onset in hepatocellular drug-induced liver injury, or the alkaline phosphatase have not failed more than 50% 180 days in cholestatic drug-induced liver injury despite stopping the suspecting offending agent. And lastly, if the liver biochemical abnormality persists beyond 180 days to evaluate for the presence of chronic liver disease and chronic DILI. So the algorithm for diagnosis patient presenting with acute hepatitis or abnormal biochemistry and you are suspecting DILI, if the patient has features of allergic skin manifestations of other organ failure, you have to carefully inquire about the exposure of drug dietary herbals, dietary supplements and herbal drug medications, drugs, over-the-counter medications, and you have to discontinue non-essential drugs and herbal and dietary supplement and expose the drug on the liver tox to search for hepatotoxicity, calculate the R ratio, investigate accordingly, exclude viral causes and autoimmune and acute Wilson if this is hepatocellular, exclude extrahepatic obstruction by ultrasound, MRCP or ERCP, and consider biopsy when indicated, as we said. Then we have to assess the severity of drug-induced liver injury. Actually, we have to score the US drug-induced liver injury network, DELIN, which classify into 5 stages based on the elevation of liver enzymes, the presence of decompensation, hospitalization, the need for transplantation, and death. And the more simplified 4-scale stage, the international expert working group, also based on the elevation of liver enzymes, decompensation, liver transplantation, and death. Then how to measure the prognosis, assessment of the prognosis of these patients. Actually, a MELD score over 19 carries a high mortality rate. And from the 1960, Heyman discovered that the combination of jaundice with the elevation of the liver enzymes carries 10% fatality rate from liver cell failure. And from the Spain registry, they suggested a new Hayes rule, which proposed a new R value that is introduced AST that can replace ALT, which one is higher, to be used in the calculation of the R value. And the new R ratio of the Hayes law better identify those at risk compared to the original Hayes law. Also, there is a web-based daily mortality calculator is available, which uses the MELD score, Charlson comorbidity index, and serum albumin. Then what about therapy? Liver damage is still an orphan hepatic disease with respect to therapy, and the most important initial step is to discontinue the implicated agent. What about specific therapy? Cholestyramine use is used in selected drugs such as leflunomide, which decrease the enterohepatic circulation of this drug and help in its elimination, as well as terbinafine. Carnitine is considered as a specific antidote for valproate hepatotoxicity. The efficacy of N-acetylcysteine to improve the severity of liver injury from drugs other than paracetamol may not be significantly substantiated. Also may not be significantly substantiated. In case of acute liver cell failure, drug-induced acute liver cell failure, dairy is the most common cause of acute liver cell failure in Western countries. In case of drug-induced acute liver cell failure, liver transplantation should be considered as a therapeutic option. Adults with idiosyncratic drug-induced acute liver cell failure should receive N-acetylcysteine early in the course, coma stage 1 and 2. In idiosyncratic daily routine use of steroid treatment may not be substantiated, but may be used if there is a hypersensitivity reaction who have progressive cholestasis despite drug withdrawal, and if there is biopsy feature resembling autoimmune hepatitis, or if there is extra hepatic manifestation of a hypersensitivity reaction, for example, severe pulmonary involvement in patient with Rett syndrome. How to prevent drug-induced liver injury. Pre- and post-market surveillance of drug during using liver biochemistry is warranted to decrease the incidence. And the systemic monitoring is essentially important for those with post-marketing boxed warning for hepatotoxicity. And the use of Hayes law should be considered to identify the patient at risk of progressive liver disease in the setting of clinical trials. Then what about specific types of drug-induced liver injury? Drug-induced autoimmune hepatitis. A number of drugs actually is associated with drug-induced liver injury, such as diclofenac, minocycline, nitrofurantoin, and etc. And in cases with diagnosis of autoimmune hepatitis, 2 to 9% were considered to be drug-induced. And also drug-induced autoimmune hepatitis account for 9% of all drug-induced liver injury. And drug-induced autoimmune hepatitis should be evaluated in detail, including serology, genetic testing, and biopsy whenever possible. And the drug-induced autoimmune hepatitis treated with corticosteroid, withdrawal of therapy once the liver injury has resolved should be accompanied by close monitoring. What about cancer immunotherapy induced drug-induced liver injury? Checkpoint inhibitors acting by increasing the anti-tumor immune response suppressing cancer, the break in the tumor tolerance is associated with inflammatory side effect and increased immune-mediated adverse events, including hepatotoxicity. And it is most substantial with the CTLA-4 inhibitors being more than the PD-1 ligand inhibitors and nivolumab, and the combination carries a greater risk. And the decision regarding corticosteroid treatment of immune-mediated hepatitis associated with immune checkpoint inhibitors are made by a multidisciplinary team involving a hepatologist if it is sufficiently severe based on clinical and histological assessment. Secondary sclerosing cholangitis, stricture of the bile duct may result from ischemia as a result of intra-arterial chemoembolization, or can occur due to drug toxicity, such as with this group of drugs. And the diagnosis is based on a cholestatic pattern of drug-induced liver injury with a slow resolution of the liver injury and the characteristic finding on MRCP or ERCP. Granulomatous hepatitis, hepatic granuloma are reported in up to 15% of liver biopsy, and 2.5% of this granulomatous hepatitis are considered drug-related. And you have to exclude, and these are example, allopurinol and sulfonamides are prototype of this type of reaction, but you have to exclude all other causes, whether fungal infection, tuberculosis, sarcoidosis, and etc. Acute fatty liver, which in the past was known as Rett syndrome in children taking aspirin, which was forbidden, it can occur with another drugs. The most important is the valproate, which is characterized by glycogen depletion causing hypoglycemia, lactic acidosis, hyperammonemia, and cerebral edema, with multiple organ failure and acute rise in the liver enzymes and jaundice. And drug-associated fatty liver disease, in NAFLD definition, which is more than 5% of the hepatocyte involved by steatosis, you have to exclude significant alcohol consumption, other causes, viral causes, for example, hepatitis C, as well as to exclude drugs that may cause steatosis, such as this group of drugs, corticosteroids, tamoxifen, methotrexate, etc. So it can, some of the drugs can cause drug or secondary NAFLD. What about liver tumor? Causal association between hormonal therapy and liver tumor is supported by epidemiological data. We know that oral contraceptive may be a risk factor for the development of hepatic adenoma, which may progress or complicated by hepatocellular carcinoma. Androgen and the androgenic steroid, particularly in treating bone marrow failure, may be considered a risk factor for such a development of tumors. Withdrawal of medication is important. Monitoring of the lesion until regression of the adenoma or definitive removal of the adenoma is warranted. At last, we need, beyond the ALT, a biomarker that detect the liability to develop drug-induced liver injury. Not only that, but also to detect which patient is more liable to more severe acute liver cell failure. At last, what is the unresolved issue and unmet need in drug-induced liver injury? Epidemiologically, the estimate of the socioeconomic burden as well as the impact of quality of life, the population-based to evaluate the risk of herbal and dietary supplement-related liver injury, pathogenesis to unmask or the factors that unmask or prevent liver injury and to determine the severity, the evaluation and validation of biomarkers that estimates differentiate those who are adapter from those who are responder, and as well as the risk of acute liver cell failure. And lastly, we need a randomized control trial to evaluate the effect of a specific intervention on the clinical outcome of DELI and a prediction algorithm for considering the drug host factors are urgently needed. And thank you very much.
Thank you, Mona, for your excellent presentation. I will ask you if it is possible to stay to the end of the session for eventually some questions.